Hello, and welcome to the discovery session on severe acute respiratory infection preparedness, also known as SARI-PREP. We have two speakers today. The first one is Pavan Bhatraju, who is an assistant professor of medicine at the University of Washington and head of bioinformatics for the Sepsis Center of Research Excellence at UW. Our second speaker is Georgia Nisi, who is an assistant professor of medicine at the University of Pennsylvania Perelman School of Medicine and an attending physician in pulmonary and critical care medicine at the Hospital of the University of Pennsylvania. We will kick off with Pavan, and you can get started. Thank you.
Thanks, Adair. I'm going to share my slides. Could you just confirm you're seeing that? Okay, perfect. Thanks. So I'd like to first thank the organizers at the Society of Critical Care Medicine for the opportunity to present. And I'm going to be presenting on behalf of the Severe Acute Respiratory Infection Preparedness Investigators, or SARI-PREP. And then here are my funding for the research I'm doing, and the top funding is from the Centers for Disease Control Foundation, and this is the group that funded SARI-PREP. So the learning objectives for this talk are to understand the process in setting up a multi-center cohort study to study severe acute respiratory infection, including COVID-19, influenza, and other viruses. Also to understand the challenges and successes with developing a multi-center collaboration during a pandemic. And then finally, I'm going to go into a little bit of our preliminary findings and to highlight some of the research questions that can be answered using SARI-PREP study. So SARI-PREP is a collaboration between clinical research networks with expertise in infectious diseases, pandemic preparedness, critical care, and special pathogens, including the National Emerging Special Pathogen Training and Education Center, or NETEC, as well as with two large consortiums, including the Society of Critical Care Medicine Discovery and the Research Network and the Resilience Intelligence Network. Funding for SARI-PREP was due to a generous contribution from the CDC Foundation. Significant knowledge gaps exist for resilience, preparedness, and response to public health measures in the United States. Past influenza pandemics have highlighted missed opportunities for clinical investigation to identify and address strategic vulnerabilities, gaps, and solutions to prevent or effectively plan future pandemics. Thus, we developed SARI-PREP to answer these two main goals. One of them was to advance our understanding of SARI by performing a deep dive into the epidemiology, pathophysiology, molecular phenotyping, and clinical outcomes of laboratory confirmed COVID-19 and comparing to seasonal influenza. We plan to enroll 1,200 patients over 2 years of study. Here are a list of the participating sites. One of the things we really tried to highlight was the geographic diversity enrollment sites. All the sites used a central IRB at the University of Nebraska. And then the Data Coordinating Center included a collaboration of investigators from Emory University, Indiana University, as well as the Society of Critical Care Medicine. All participating sites were enrollment sites, and all biospecimens that were collected were transferred to the University of Washington and are being held for long-term storage as well as different molecular analyses. So the inclusion criteria for enrollment, we wanted to prioritize enrollment of patients early during their hospital admission. And so we prioritized a 72-hour window for study enrollment. Patients needed to have fever, cough, as well as one of the following, which included radiographic infiltrates by imaging, or an oxygen saturation less than 94% on room air, or they needed to require new supplemental oxygen, or being receiving invasive or non-invasive ventilation. And then they also need to have a confirmed viral case for SARI by respiratory viral RT-PCR testing. Exclusion criteria were pretty basic, but included inability to obtain consent, as well as one of our primary outcomes was time to mechanical ventilation. And so patients were had a do not resuscitate order prior to hospital admission. Their enrollment sites, each of the enrollment sites had quite a few different responsibilities. One of them was obtaining consent for patient enrollment, and all consent was done through an electronic process. There was no paper consent, and often consent was through a legally authorized representative. In prior studies, LAR consent was common, but one of the added challenges with COVID-19 was that during different times during the pandemic, LARs were not allowed to visit the hospital. And so often consent was done remotely, and study personnel couldn't have face-to-face interactions, which made consent oftentimes challenging. One of the other challenges was as the pandemic progressed, study enrollment was lower in patients who were potentially hesitant to receive a vaccine prior to hospitalization, and potentially also hesitant to participate in research. Other responsibilities of the enrollment sites included detailed daily completion of case report forms, also completion of weekly surveys that assessed hospital stress, strain, and capacity. And Dr. Nisi, who's coming next, is going to be talking more about this. And then also detailed biospecimen collection. Here's a table of the timeline for when biospecimens were collected. There's 4 main time points during hospitalization. The first collection was within 72 hours of hospital admission, and then the last collection was as close as we could to hospital discharge. There was then follow-up collection as an outpatient, and there is various different types of biologic sampling. So from DNA, peripheral blood, RNA, plasma, peripheral blood, mononuclear cells, as well as urine collected in patients with an indwelling Foley, nasopharyngeal swabs. And then if patients were receiving invasive mechanical ventilation, lower respiratory tract specimen collection. To date, SARI-PREP enrollment started in April 2020, and to date we've enrolled 750 patients. There's been over 2,600 plasma aliquots, 800 nasopharyngeal swabs, over 2,000 urine specimens, and 316 peripheral blood mononuclear cells. We've also really tried to utilize the breadth of investigators within SARI-PREP to take a holistic approach to study different factors that could lead to poor outcomes in COVID-19, as well as other viral causes, and to potentially identify therapeutic targets or even modifiable factors to improve outcomes in patients with SARI. And so some of the analyses that have been completed or underway include plasma and urine proteomics, which are being done at University of Washington, humoral profiling to understand the immune response, especially with different SARS-CoV-2 variants, which is being done in Nebraska, peripheral blood transcriptomics being done at New York University, and then viral sequencing, human genotyping being completed at University of Washington, and then hospital stress and strain. For the next few slides, I wanted to go over some of the preliminary findings we've generated within SARI-PREP. And partly it's to showcase what some of the science that can be done, and hopefully give a snapshot of what's coming down the road. So this is specifically looking at, there's been quite a few papers that have already looked in COVID-19 at a priori biomarkers that are associated with severity of illness or outcomes. However, we wanted to go through a discovery proteomics approach to identify, are there some previously unknown markers that could be associated with COVID-19 severity? And so in 101 hospitalized patients with COVID-19, we used a SomaScan platform. It's an aptamer-based platform that uses short oligonucleotides, which have binding affinity to single proteins. The benefit of SomaScan compared to other proteomics platforms is the ability to multiplex thousands of proteins. Here we were able to measure over 5,000 at one time point with a single blood specimen. The measurements have low coefficient of variation, and there's been now quite a few cohort studies that have used the similar platform, and so we're able to compare data across studies. And the outcome we looked at was 28-day ventilator-free days and hospital mortality. Sorry about that. So this is looking at some of our primary findings. So on the left here is a volcano plot. On the y-axis is the negative log 10 p-value. Higher values on the y-axis are more significant. On the x-axis is the association with ventilator-free days. So proteins to the right of 0 are associated with higher number of days, higher ventilator-free days, or more days free from mechanical ventilation. Proteins left of 0 are associated with fewer ventilator-free days. And then each dot on this plot is an individual protein. And then here at the top is the Bonferroni corrected threshold. And so as you can see, hepatocyte growth factor was the protein that was most associated with fewer ventilator-free days. Higher concentrations of HGF were associated with fewer ventilator-free days. And there's been multiple papers already in COVID-19 showing that this protein could be associated with clinical outcomes. And so it supported the generalizability of our findings. One of the other proteins I highlight here that was interesting was angiopoietin-like 4. This was the most significant protein that was involved in endothelial dysfunction and capillary leak. And it's one protein that hasn't really been studied that much in COVID-19, but there's been a few papers looking at the importance of this pathway in influenza. So with that, one of the things we wanted to do was look at how correlated is ANGPTL4 to other markers of endothelial function. And interestingly, we found that ANGPTL4 was moderately correlated with vascular endothelial growth factor, but compared to other markers of endothelial function, the correlation was quite minimal, potentially arguing that ANGPTL4 is a distinct pathway from previously studied pathways in COVID-19. There's been a paper showing that ANGPTL4 binds through a neuropilin receptor, and neuropilin has been shown to be a co-receptor for SARS-CoV-2 infection. It's also been shown that soluble neuropilin-1 is a sink for ANGPTL4 and prevents ANGPTL4's biologic activity. And so one of the things that was nice to see in this correlation matrix was that ANGPTL4 was minimally correlated with soluble neuropilin-1, potentially arguing that what we're measuring in the circulation could be biologically active. And then finally, we were able to replicate these findings. Also in SARI-PREP, this was a cohort that included patients enrolled from NYU, USC, as well as the University of Washington. We're also able to measure ANGPTL4 using an ELISA assay to help with reproducibility. And what we found was that higher ANGPTL4 concentrations were associated with fewer ventilator-free days, also worse hospital mortality, and that circulating concentration were associated with the development of acute respiratory distress syndrome and thrombosis. And so this is just some of the work highlighting the importance of this pathway in COVID-19, but also a potentially an area for future exploration. And then finally, I just want to end with successes and challenges that we've seen already. Some of the successes, we were able to enroll across multiple sites with geographic diversity in the US. We were able to complete detailed phenotyping, which included often daily phenotypic data, as well as longitudinal biospecimen collection during hospitalization. And then able to develop a network to facilitate potentially future studies, including clinical trials. Some of the challenges that we faced were that obtaining IRB approval, even using a single IRB, was quite slow, especially it varied based on sites. And so that really slowed us down from enrollment early in the pandemic. One of the other challenges was that most of the case report forms were completed by manual extraction by research coordinators. And this was particularly time consuming, but there's been work underway to try to automate this process, and the Society of Critical Care Medicine, as well as others, have been working to hopefully be able to automate some of this data collection that can go into case report forms. The other challenge was harmonizing the case report forms specifically for SARI-PREP with other COVID-19 observational studies, including the virus study, as well as ISARIC and others. And one of the biggest challenges was that the definitions for the same variables were potentially different across studies. And so it may prevent some of the sharing of data. And so I think in the future, that's going to be one of the important things to consider when developing such cohorts. And then the final piece was competing clinical trials. Especially early in the pandemic, there are quite a few different clinical trials, observational studies occurring in COVID-19. And it was really relied on the specific institution level to coordinate these studies and hopefully present them to the patients of the LAR at the same time and say, these are the options of studies available at our center, and you can choose which ones you want to be a part of. But often that wasn't done at all sites, and so it's a little, times you didn't want to overwhelm family members with enrollment. There's a lot of people I'd like to thank. Here's a list of the investigators who've been part of SARI-PREP. I also want to specifically thank the research coordinators, research scientists, and study personnel. There was quite a few people who worked on this study together, and it's been really great what they've been able to do. So I'm going to be stopping there, and I'll turn it over to George and Nisi, and he'll be taking over. So stop presenting.
All right, I'll bring up my slides. All right, and Adair, can you confirm that you can see those?
Yes, thank you.
All right, thank you so much. So thanks to my colleague, Dr. Bhatraju, for an excellent talk, and thanks to Adair and the organizers for the invitation to speak. My name is George Nisi from the University of Pennsylvania. I'll be talking about hospital stress, adaptation, and resiliency during respiratory viral acute surge events. And again, in my role as a co-investigator of the SARI-PREP study. So here's the funding for the study, as Dr. Bhatraju mentioned, as well as funding for other work I've done, and then some financial disclosures, none of which I believe are conflicts for this talk. So I have three learning objectives. The first is to understand the operations concept of hospital stress, also called healthcare capacity strain, and acute surge events. Second is to understand the phenomena of hospital adaptation and resiliency. And the third is to report interim results of the SARI-PREP hospital stress assessment and related future work. So we'll start with hospital stress or healthcare capacity strain. This is where my research interests niche lies. And this is an operations concept that says that there are limits that are placed on a care team, a ward, a hospital, any unit of healthcare delivery on their ability to provide high quality care for all patients who may need it at a given time. And we know that there are kind of numerous patient system factors that can contribute to healthcare capacity strain. And these include occupancy and turnover, more patients, acuity, the sickness of the patients who have unique care demands, things like isolation, level of care, and equipment and personnel needs. And then if there's a concomitant reduction in supply of resources, the places to take care of patients, the specialized personnel to take care of them, and the equipment, the stuff, the medications and equipment to deliver that care. And so this is a conceptual piece that Laura Evans and I, co-investigators on SARI-PREP, authored together in Critical Care Explorations that proposed that healthcare capacity strain exists along a spectrum. Under the umbrella of dynamic strain, kind of in the middle of the spectrum, you could imagine things like random variation and semi-predictable seasonal changes. But all the way on the extreme end of the spectrum are things called acute surge events, where there's a dramatic increase in demand for care. And obviously, we're all become very intimately familiar with this over the past 2 years. It certainly can include things like epidemics and pandemics, but also natural disasters, infrastructure breakdown, and attacks on the public. And then all the way on the other end of the spectrum, under an umbrella that we call static strain, is care delivery in persistently resource-limited settings, where there's kind of a persistent mismatch in the supply and demand of critical care. And certainly there can be kind of acute on chronic, dynamic on static scenarios. we've studied ICU capacity strain for a long time now in my various collaborations, and this is one example to show a few measures of ICU capacity strain and one measure of ward strain that show these phenomena of both among and within hospital variation. So 3 hospitals within my institution, the Penn Medicine System, that show even on a very granular level dynamic changes from hour to hour of ICU occupancy, turnover, and census acuity, for example, both within a given hospital, a given colored line, or among hospitals over time. And then looking at a very kind of hyper-local level, we looked at the relationship between ICU occupancy, which emerges as a very influential strain metric, and care delivery, and in particular, the likelihood of the next patient being admitted to the ICU. And we found here that if you move your eyes from right to left, we see that at around 6 open ICU beds remaining, or about 70% ICU occupancy, the likelihood of the next patient going to the ICU starts sequentially decreasing with sequential increases in ICU occupancy. So it's not just a phenomena of saturation, full or not full, there actually start to be care delivery changes well in advance of that last bed being full. And so kind of leading from this in a conceptual piece in the SCCM Critical Connections magazine, the SARI-PREP investigators proposed a conceptual framework for this concept of hospital adaptation, which is the ability to improve care and outcomes for infected or primarily affected patients during a surge event by implementing new care processes based on accumulated experience. So how we get better over time. And here's a kind of a real world example of that from our recent history during the early parts of the COVID pandemic. This is data that came out of my health system at Penn, where we showed that very rapidly over the early part of the pandemic, mortality for COVID critical care patients improved. Really just in 2-week increments, we saw improvements, and over an 8-week period in the early part of the pandemic, we saw mortality decrease from about 45% to around 20 to 25%. And this held consistent after robust adjustment for patient level factors. And so clearly something we were doing here was changing and doing better, and we were adapting to this new threat. And we started to investigate what might that be, and we certainly found changes to our practice patterns, both quantitatively and qualitatively. We saw a very swift reduction in the proportion of patients that we were mechanically ventilating. That was a common practice change that occurred in the early part of the pandemic. But even when restricting to patients just mechanically ventilated, we still saw that mortality signal improve over time. So that's not the full explanation. And so this is a schematic of our COVID critical care task force. I'm sure every hospital in the country can produce a similar schematic, all the different changes that we made, a very rapid cycle over the early part of the pandemic. So it's kind of real-time adaptation in a learning health system. And we don't yet know exactly what accounts for that improved mortality. Certainly the general vote is in favor of us getting better and better at adhering to evidence-based therapy in the setting of very austere and adverse circumstances. But there's certainly a lot more nuance there. And so that's a real world example of hospital adaptation. And on the flip side, which I'll talk about a little bit less today, but is important, it goes hand in hand also from that conceptual piece that the SARI-PREP investigators authored, is a concept called hospital resiliency. This is the ability to continue to deliver high quality care to uninfected bystander patients despite the presence of a surge event. So not in the setting of COVID, for example, it's not the patients with COVID who need hospitalization or ICU admission, but it's all the other patients without COVID who still require acute care during the pandemic. And I'll give you a few examples from the literature of phenomena that we think fall under this hospital resiliency. One is a hyperlocal example. This is a very interesting, small but very interesting study from a couple of years ago now in JAMA that looked at what happened in a hospital ward when there was a critical illness event, and then what happened to the risk to all the other patients, not the patient that experienced that initial event, but all the other patients on the ward at that time. And what it showed was that if there was a critical illness event in the prior 6 hours, all the other patients had an increased odds of a cardiac arrest or an ICU transfer over the next 6 hours. And that was true over, of course, a lot of different modeling approaches, and there was dose response. So one event compared to greater than one event, the risk was even greater to again, those totally bystander patients. This effect decayed over time, but still persisted for quite a bit. So even at the 12-hour mark, there was still a heightened risk to all those other bystander patients based on a single critical illness event 12 hours prior. And so clearly you get a sense for this kind of shunting, potentially shunting of resources from the kind of the care of the full population to the care of a single patient that underwent a bad event, and depriving potentially those other patients of kind of continued highest quality care. A more contemporary example during the COVID pandemic is a study out of Brazil that showed their critical care outcomes had been undergoing a multi-year period of improvement over time, consistent with large studies that show, for example, improved sepsis outcomes consistently over time. And about 4 years of gains of that improvement was lost during the pandemic very, very swiftly, where in their non-COVID patients, their outcomes got much worse during the pandemic. So obviously, this is there's a lot of nuance to teasing out causal effect here and kind of appropriately measuring that impact. Certainly, the COVID has changed care delivery in a lot of different ways and changed even the populations that were in the ICU, but certainly as a hint to that that hospital resiliency signal. And then most recently, an example from the US, this was data from the US Department of Homeland Security COVID task force, which showed that there's a strong relationship between ICU occupancy and total population excess deaths, not just hospitalized, not just ICU, but total population excess deaths, such that starting to get into the 60, 70, 80% ICU occupancy range around the country or regionally, you saw a real increase in excess deaths, all-comer excess deaths in the population. And that's interesting. That if that were causally tied, that would really be a strong example of shunting of resources. And I just note with interest that an inflection point around say 70% or so, mirrors our kind of hyperlocal study that I proposed earlier, that I showed earlier about 70% ICU occupancy being the point at which care delivery really starts to change. An interesting seeing an inflection point similar on a hyperlocal level and on a population level. So looking now to the specific SARI-PREP work in this niche. So as my colleague, Dr. Bhatraju told you about, SARI-PREP is a prospective cohort study that looks at SARI characteristics, biological profiles, and outcomes, among many other aspects. But one of the embedded pre-specified assessments and aims within SARI-PREP was a longitudinal assessment of perceived hospital stress due to SARI patients. And so this was accomplished by a weekly hospital stress survey that was started in November 2020 and continues to the present day. It's rolled out every week to site leaders in the SARI-PREP study. And it asked them to assess their perceptions of hospital stress, ED stress, ICU stress, or different levels of care within their institutions, deviations from standard operating procedures over a broad list of different resources, and then staffing and equipment availability, again, over a broad list of different resources. And we additionally paired that, as we've entered kind of an analytic phase, pairing that with local and regional SARS-CoV-2 case trends that were extracted from public health departments, kind of contemporary viral activity in those regions. And so I'll show some interim results. This assessment goes on to to the present, and so there'll be a complete analysis down the road. But at one point, an interim analysis which had data from 8 hospitals across 3 health systems in New York, California, and Washington, and contributed at that point 190 hospital weeks of data. Now much more. And I'll highlight a few findings. One is that sites reported the unavailability of some hospital resources, resulting in potentially avoidable patient harm in just 3.5% of weeks. But they reported alterations in care processes and staffing, which were fully compensated for in 57.9% of weeks, and no stress in just 38% of weeks. And then the most common care deviations were increases in hospital staffing and elective surgeries, canceling of elective surgeries, which occurred in 39.5% and 18.6% of hospital weeks, respectively. And then an interesting note is that stress was far more commonly reported in ICUs at 72.4% of weeks, compared to emergency departments at 14.3% of weeks. From a staffing standpoint, about a fifth to a third of hospital weeks required some reassignment of clinical staff, which is a big disruption to normal operating procedures. In particular, residents and fellows, so trainees, were most commonly pulled for what we'd consider out of scope ICU practice, so beyond their existing training. And that occurred in almost 12% of hospital weeks, which is quite a bit of kind of out of scope practice compared to kind of usual care. From a medications and equipment standpoint, during at least this period during the pandemic, shortages of medications, respiratory support were fairly rare. The respiratory protection equipment shortages was the most common and impacted clinical protocols during about 30% of hospital weeks, which is certainly an impactful figure. And a very interesting finding that we're continuing to investigate and tease nuance out of is the fact that hospital stress and care deviations were highly correlated, that you see on the left there, with an R of 0.81 at this point in the analysis. But when we add in ICU and ED stress, those were not as well correlated, in fact, with an R value of 0.19. And so we saw this phenomenon whereby ED stress rose and abated earlier during a wave. And then ICU stress and care deviations persisted, ranging from kind of 2 to 13 weeks longer as local case rates declined. And I'll show you one kind of representative study site example of this phenomena. So this is a study site that was experiencing, kind of one wave of cases that was declining, nadir'd, and then began to rise again. And you see the orange and yellow curves representing state and county SARS-CoV-2 incident cases that are in the surrounding area, respectively. And then we see that ED stress, which is represented by this kind of purple plus sign, abated earlier during that decline, while care deviations, represented by the kind of blue medical bag, and ICU stress, represented by that turquoise face, persisted, in this case, additional kind of 12 and 13 weeks, respectively, after the ED stress abated. And then when cases start to rise again, very quickly, ED and ICU stress were again reported together. And so some kind of interim conclusions from the SARI-PREP hospital stress analyses are that hospital stress during the pandemic varied both in degree and type, and both within and among hospitals over time. That hospital ED and ICU stress behaved differently, again, both in degree and timing. And while care deviations were very common, potentially avoidable patient rare was perceived to be rare. Staff reassignments are also very common, with trainees being the most commonly pulled for out-of-scope ICU service. And then equipment shortages were largely limited on an absolute scale, were largely limited to respiratory protection. So a few kind of ongoing and proposed future analyses, planned future analyses as part of SARI-PREP and beyond. The first is to look at the relationship between hospital stress and SARI individual patient care delivery outcomes. That'll be linking the hospital stress data that I've reported here to the individual patient level data that Dr. Bhatraju presented, and that's been a core aim of SARI-PREP. Additional potential analyses are looking at nuances and different measures of perceived hospital stress, and looking at both qualitative perceived hospital stress and quantitative, so numerical numbers of hospital stress that can be paired with this. And then finally, looking at additional nuances of hospital stress measures and regional case trends. So a parting thought is that systematic national assessments of hospital stress, both during and between pandemics, really could inform more rapid and proactive public health responses to novel threats. This is something a lot of us have envisioned in this niche for a long time and is yet to be fully realized. And so we'll continue to battle towards that goal. So I'll also say thank you to our numerous collaborators. This is a non-exhaustive list of SARI-PREP, those that play particular roles in our stress analyses, but thanks to everyone as part of that team. And then to my additional collaborators at Penn and other institutions for some of the data that's presented today. So I'll stop there and say thank you for listening.